Futibatinib, fibroblast growth factor receptor inhibitor, tyrosine kinase inhibitor, anti-neoplastic agent, used for the treatment of previously treated, unresectable, locally advanced or metastatic intrahepatic cholangiocarcinoma, harboring fibroblast growth factor receptor 2 gene fusions or other rearrangements. Used for adults, and it could be administered with or without food at approximately the same time each day. Swallow tablets whole and don't crush, chew, split, or dissolve. When it comes to the dose regimen, the recommended dose is 20 mg once daily until disease progression or unacceptable toxicity. If a dose is missed for more than 12 hours, or if vomiting occurs, resume Futibatinib dosing with the next scheduled dose. And we should also notice that the recommended Futibatinib dose reductions for adverse reactions. First, as initial starting dose 20 mg once daily. First dose reduction is 16 mg once daily. Second dose reduction is 12 mg once daily. We should permanently discontinue Futibatinib if unable to tolerate 12 mg once daily. Adverse reactions and concerns. Hyperphosphatemia. Futibatinib may cause hyperphosphatemia leading to soft tissue mineralization, calcinosis, non-numeric calciphylaxis, and vascular calcification. Hyperphosphatemia occurs in the majority of patients who received the Futibatinib. The range of occurrence of hyperphosphatemia is from 3 to 117 days. Phosphate binders were administered to over 3/4 of patients. Futibatinib may cause retinal pigment epithelial detachment with a characteristic blurred vision symptom. The first onset of RBED is 40 days. Mechanism of action. Futibatinib is a selective irreversible fibroblast growth factor receptor kinase inhibitor that covalently binds and inhibits FGFR1, FGFR2, FGFR3, and FGFR4 enzyme activity. FGFR phosphorylation inhibition results in decreased FGFR-related signaling and decreased cell viability in cell lines expressing FGFR genetic alterations, leading to decreased proliferation and survival of malignant cells. Distribution: 66 liters with 95% protein binding, primarily to albumin and alpha-1 acid glycoprotein. Metabolism: primarily hepatic via cytochrome B3A, and to lesser extent to cytochrome, and to a lesser extent by cytochrome B2C9 and 2D6. Half-life elimination: 2.9 hours. Time to peak: 2 hours. Excretion through feces. Clearance: 20 liters per hour.